So yeah. So how this neurodiversity and autism spectrum disorders are associated? We know that autism spectrum disorders are associated with differences in their communication behavior, and these differences might vary from child to child. We know that no two children on spectrum are ever same. And there is a very famous saying that if when we met one child with autism, we met another child with autism. That means to say no two children on spectrum will be ever same. If you stand hundreds of autistic child in a row, every child will have their own peculiarities, strengths, and weaknesses. So that is exactly that these differences might vary from child to child in their communication, in their behavior, and how they look the world and perceive the world. So people with ASD may have wide range of strengths, their abilities, needs, and challenges. For example, some autistic children may be able to communicate verbally, while others may not be able to communicate verbally, might be having low IQ, and some might require life dependency, and some might live independent. So this is the variation of the spectrum of autism spectrum disorders. And others might not be able to communicate their needs or feelings at all. That means they would be requiring struggling, and they will be requiring dependency throughout their ADLs, that is activities of daily living. And according to that, we can classify them as mild, moderate, and severe, or level 1, level 2, level 3 dependency. So this exactly was the term, the purpose of this neurodiversity to include with autism spectrum disorders because of the variation of presentation of this spectrum disorder. Now, something about that is to focus, this slide is to focus that the neurodiversity is now being considered as a part of the neurotypical or developing children, neurotypical developing population. That means to say, nowadays, more and more industries are being fostering neurodiversity in the workplace. And this is some of the data which I will share you in the next slide, that there is a lot of stigma, lack of awareness, and lack of appropriate infrastructure, such as office setup, staff, can cause exclusion of people with neurodevelopmental differences. So we know that many a times people with ADHDs, people with autism have been thrown out from the offices because of XYZ reasons, because of bullying nature, because they are not able to cope up with the things, they are not able to judge the scenarios. There can be so many reasons. Kindly mute yourself. I request delegates to kindly mute themselves. So understanding and embracing neurodiversity in communities, schools, healthcare settings, and workplace improve the inclusivity of for all people. So including and understanding the concept of neurodiversity is very, very important for us as a clinicians so that we can able to understand their differences and how they perceive the world. We cannot just ignore them. Considering us as a part of community along with schools and other communities, we need to include them. That is why we talk about inclusion. We talk about so many things about inclusion, but really, do we really see that this inclusion is happening at the ground level? In reality, I think it is not happening to that extent. We do talk about inclusions everywhere, but in particular, still there are lack of infrastructure, lack of, I would say, educated staff, and lack of trained staff to teach and manage these children who are on the spectrum or who are coming under neurodiversity. Still, lot of work needs to be done if we talk about especially at the school level. So it is important for all of us to foster an environment that is conducive to neurodiversity and to recognize and emphasize each person's individual strengths and talents, and thereby supporting the differences and needs. Now, one of the most important things which we always forget when we are dealing with children on neurodiversity is we always focus on their weaknesses. We always focus on the weaknesses. We always try to improve the weaknesses. Many of the times we neglect their strengths. Now, for example, in children with autism spectrum disorders, they have a lot of fixations. They have a lot of obsessions about a particular thing that has to be kept in this way. And many a times, just to give an example, if there is a shoe is there, there are two pair of shoes are there, green and yellow. They have to be kept only in this order, green, yellow. They will be very, very fussy to keep that order maintained. But we are considering that as a deficit, but probably if we consider them as a strength, it can be very, very useful for them in further scenarios or in their different scenarios, because it is something which they are keeping the things organized. They want it to be kept them very peculiar or very precise, but considering them as a deficit every time is not the right thing. And this is some of the data which I have taken from the top MNCs which are hiring autistic individuals on the basis of the ground, because we are now promoting neurodiversity. The concept of neurodiversity awareness is now being coming up. So this is the data which I have taken from 31st Jan 2022 till 22 data. So Ernst and Young, JP Morgan, Apritech, Divergent, and Spectrum. These are some of the top MNCs which are now started hiring children's on neurodiversity, whether it is an ADHD, whether it is a LD, whether it is an autism spectrum disorder. So this is a Dell Autism hiring program which was initiated, and they were recruiting these children on neurodiversity or neurodivergent job seekers, and especially this was opportunities were created for neurodivergent job seekers. Then if I come according to so these definition which I shared you the definition previously, that was the definition as per the Harvard Medical School. If I share you the definition of neurodiversity as per the World Economic Forum, which was conducted in 2021, so neurodiversity is considered to be as a non-medical umbrella term that includes conditions like autism, dyslexia, dyspraxia, dyscalculia, and ADHD. So broadly, it includes autism, ADHD, and LD. So I have mentioned the reference also. So as per them, neurodiversity is not considered to be a medical term. So probably when we are going through our old medical textbooks, and especially we go through the Nelson and if we go through the OP Ghai or any standard pediatric textbook, they mention autism as a neurodevelopmental disorder. So probably in the years to come, we should give a thought whether it should be considered as a neurodevelopmental disorder or it should be considered as a neurodiversity of a typical developing brain. So that thought needs to be given probably in the years to come, whether we should use this term as a developmental disorder or a neurodiversity. So teams with neuro, and this is another important data which I have taken, that teams with neurodivergent professionals is a very shocking and very interesting data for us. Teams with neurodivergent professionals can be 30% more productive than those without them. But there is a greater incidence of mental health difficulties like anxiety, depression among neurodiverse individuals. Now, this is the most important problem, and this is the most common thinking among us, that we are focusing upon their deficits like anxiety and depression. We know it is very, very common in children, in teenagers and adolescents with ADHD. But we forget about the fact that they have some other peculiarities, their strengths. And because of their strengths, professionals who are hiring neurodivergent professionals are 30% more productive. So according to the World Economic Forum, everyone is different. There is no single right way. There is no one right, no one wrong. And everyone looks the world in a different way, behavior, and their own differences. So these differences are not considered to be as deficits. They are considered to be the variations of the developing brain. And between 10 to 20% of the global population is considered to be the divergent. This is the data which has been taken from auditing consultancy firm Deltoid. So this is the data which says that 10 to 20% of the global population is considered to be divergent. So that this percentage is quite huge. So the term recognizes the fact that certain developmental disorders are normal variations of the brain. And while neurodivergent people may have difficulties, they may also have certain strengths. So again, the whole purpose is we should focus on their strengths. No doubt we should also work on difficulties. But many a times our focus is to focus on their difficulties rather than to improve and promote them on their strengths. So these are some of the facts which were taken from World Economic Forum 2021. Autistic brains are said to be highly creative with exceptional concentration, imagination, and visual thought. And they also tend to be systematic, meticulous, and share unique insight and perspectives in problem solving. And among this autistic brain, there is one term which we use known as Salvin syndrome. Now, Salvin syndrome is nothing. It is considered to be the mild autism spectrum disorder or a high functioning. Now, these kids, they have an exceptional concentration and unique imagination. No doubt, they have some deficits where we as clinicians or neurotypical population might consider as a deficits, like they are very meticulous. They have exceptional concentration in the sense they are very obsessed to keep certain things in that particular order. But if we use those concentration powers and their meticulous abilities in different categories of their job or in different scenarios, probably we can, we can produce the results much, much better. So Savant syndrome is one such example where they have unique abilities in problem solving, mathematical solving, and XYZ. Probably their creative, their brain is so much creative, which is even more than that of the neurotypical brain. And one thing is very, very important. Autistic brains, there are three different types of learning. We know that kinesthetic learning, we know that there is auditory learners, and we know that there are visual learners. Autistic brains, they have a very good brain mapping. So they are very good visual learners compared to auditory learners. So give it a thought whenever you are dealing with a child who is on the spectrum, you visualize him by giving certain pictures rather than giving him an auditory text. He will respond to you much, much better when you are giving him a visual text rather than auditory text. That is because of the reason they are good visual learners and they have a very good brain mapping. Now, people with ADHD have a great imagination and score higher on creativity tests than non-ADHD. And again, ADHD people are hyper focused, which means that while they generally have an attention deficit, they do have a high focus on area of interest. This is the report which has been given by CNN. So again, the purpose again for these slides and to show the neurodiversity slides is considering deficits is not important, but considering their strengths is much, much more important, because they can create better results and better awareness among the global population. And again, an important data which comes out is dyslexic people have demonstrated the ability to think outside the box. 84% of dyslexic people are above average in reasoning, understanding patterns, evaluating possibilities, and making decisions, according to the charity which is made by Dyslexia. And it has been even shown on this data that the population which is the corporate population which is including dyslexic people in their groups, their results, their progress is much, much higher compared to the population which is only catering with neurotypical peoples and who are throwing children who are neurodiverse or coming under the neurodiversity. So this whole includes the idea of inclusion. So regarding, if we go through all these previous slides and what we have discussed about neurodiversity, taking into consideration the definitions by World Economic Forum and Medical Harvard University. So can we say now that all these various terms coming under umbrella LD, that is learning disability, dyslexia, dyscalculia, apraxia, autism spectrum disorders, or ADHD, are they should be considered as a normal variants of the developing brain, or should we still consider them as a neurodevelopmental disorder, lifelong neurodevelopmental disorder, which is the traditional definition which we used to study and probably which we are still reading in our textbooks. So this was the definition as per the medical textbook of definition of autism. It's a neurodevelopmental disorder, disability of variable severity with lifelong effects that can be recognized from early childhood, chiefly characterized by difficulties with social interaction and communication and by restricted or repetitive patterns of thought and behavior. So now I think it's a time that we should give a revamp to this definition of autism in our medical textbooks. So now let's come out to be what are coming under autism spectrum disorders. So under autism spectrum disorder, these were all the classification which were given initially, like classic autism, autism spectrum disorder, Asperger's syndrome, speech language disorder, social communication disorder, Rett, pervasive developmental disorders not otherwise specified. So these were all the terms which were being used under autism spectrum disorder, but there are two things: social communication disorder and speech language impairment. They do not come under ASD. Now, social communication disorder, SCD, is one such new definition which has now been coming under DSM-5, which was not present in DSM-4. DSM-5 was introduced, I think, in 2011, which was, so before that, there was no such definition of SCD. There was no such term which was existed. Only after 2011, when DSM-5 criteria came, SCD started appearing, and there was a separate diagnosis which was coming under DSM-5. It is not included under the ASD. So what is the old classification of DSM-4? So this was the old DSM-4 classification which we used to study in our OP Ghai and Nelson. So autism spectrum disorders were divided into different: classic autism, Asperger, pervasive developmental disorders, not otherwise, and high functioning autism, which is basically considered to be as a Savant syndrome. So what was the problems with the DSM-4 and ICD? Now ICD-11 has come. So what were the problems with DSM-4? Subtypes were not distinguished by the prognosis, etiology, and neuropsychological profiles and treatment. It was totally inconsistent. It was not able to distinguish between social communication and interaction. That means this DSM-4 was not able to differentiate whether it is an autism spectrum disorder, whether it is a social communication disorder, or whether it is speech language impairment. Then there was age of onset of exclusion was there. So certain age criteria was mentioned. And the one of the most important thing is, as we know, autism and ADHD are associated with so many comorbid conditions like gut problems, gut issues are there, sleeping issues are there, obesity issues are, anxiety, depression, so many issues are there. Those were not included in DSM-4. But the greatest advantage of DSM-5 is it is also including the comorbid conditions which are associated with autism and ADHD. So if I show the variation in tabular form, different ICD versus ICD-11, DSM-4 versus DSM-5 is, in DSM-4, all pervasive developmental disorders, Asperger, PDDs, all were coming under autism spectrum disorders. They were different classifications were given. So now in DSM-5, all these have been clubbed together as a single term, that is autism spectrum disorder. So it means to say the take home message is, on your prescription, now there is no need to write as an Asperger, PDD, NOS, Asperger, pervasive developmental disorder. Whatever it comes under autism spectrum disorder. So now there is only a one single umbrella term known as autism spectrum disorder. So now we do not use the term also classic autism or simply autism. We use it as autism spectrum disorder because it's a spectrum. It's not a single term or diagnosis. Similarly, in ICD-11, they have used the autism spectrum disorder. Another important thing is in ICD-10 and DSM-4, they were using 3 symptom domains. But now in DSM-5 and ICD-11, they are using only 2 most important domains. These are behaviors and sensory issues. So the 2 most important domains are behaviors and communication issues. Now in ICD-10 and DSM-4, they have mentioned onset of age by 3. This was the inclusion criteria of age which was included in ICD-10 and DSM-4. But in DSM-5 and ICD-11, they have removed this age of onset. That means to say it can be diagnosed at any particular age, irrespective of the fact of age of onset. Now, in DSM-4, they were using these terms PDD, NOS. They have been replaced totally. They're coming under new term, that is autism spectrum disorder. So another important thing in DSM-5, they have introduced a new term, as I have told you, social or pragmatic communication disorder, or known as SCD, which was not present in DSM-4 or ICD-10. Another important differentiation feature is that in DSM-5, the diagnosis of autism spectrum disorder becomes much, much easier. Also, there is an overlapping of ADHD. In DSM-4, you cannot make a combined diagnosis of autism with ADHD. We know that there are so many overlapping features of autism with ADHD that sometimes, especially in children, the ADHD part goes masked in the picture of autism spectrum disorder. Autism spectrum disorder takes the dominant position when there is an underlying ADHD symptoms are present, because as per the definition also, we cannot make a diagnosis of ADHD unless and until the child is 4 or more than 4 years. In very rare cases, we can make a diagnosis of ADHD as a term using atypical attention deficit hyperactivity disorder when you are 100% assured that the features of impulsivity and hyperactivity are present in that child. Only when you are making a diagnosis of ADHD in a child less than 4 years, you use the word atypical ADHD. Otherwise, we cannot make a diagnosis of ADHD less than 4. We can use the word overactive, but we cannot use the word hyperactive in a child less than 4 years. So this was the peculiarity of DSM-5, that ICD-11, that you can make a combined diagnosis of autism with ADHD, also including the comorbid features associated with autism and ADHD, which was not there in ICD-10 and DSM-4. So in DSM-4, again, there was a different types, autistic, red. These were the different classifications or subcategories of autism spectrum disorder. But now they have all become obsolete and they have become a single disorder of ASD. Now, this is the main criteria which we now use for DSM-5 for diagnosis of autism spectrum disorder. So there are 2 most important criteria, criteria A and criteria B. Criteria A includes behavior, criteria B includes sensory. Now, this sensory is the new criteria which has now been introduced, which was not present in DSM-4. Now, in criteria A, they include the behaviors which include the social emotional reciprocity, non-verbal social communication, and reciprocal relationships. Now, these 3 domains in criteria A should always be present. Whereas in criteria B, out of 4, any 2 can be present. That is unusual sensory interest, restricted stereotypic. Earlier in sensory, they were only using one word, that is repetitive stereotypic movements or repetitive stereotypic behavior, which we known as stimming. That was the only criteria which was used in DSM-4. But now they have included a proper criteria of sensory, which include these 4 parameters. So out of these 4, any 2 has to be met. It is not only repetitive stereotypic, but it is adherence to routines, restricted or intense interest, or unusual sensory interest or reactions towards a particular. That is, the child might be hypersensitive, hypersensitive, a seeker, or maybe a mix towards a particular sensory stimuli. So these are some of the new additions which has been made in DSM-5, along with problems which are associated with the comorbidities, like they might be adaptive functioning, they may be ADHD, anxiety problems, gut issues, they may be language impairment, they might be so many functional and cognitive impairments or delays. So these were some of the associated comorbidities which were now being present in DSM-5, which were not present earlier in DSM-4 or ICD-10. So a word about what does this social reciprocity means, which comes under the criteria for communication. So being aware of emotional and interpersonal cues to others. That means to say the most important, a 6-month-old child, if you take a 6-month-old child on your lap, if a mother takes a 6-month-old child in her lap and mother gives a smile, the infant gives a smile back. A typical 6 to 7 age. Now, this is typically an example of social or reciprocal imitation or social reciprocity. That means the child responds to you back. Now, this typical expression or facial expression or social reciprocity is absent in a child when it comes onto the autism spectrum disorder. So this means to say that we can pick up a child suspected with autism spectrum disorder as early as the age of 6 months. But as per the guideline, the diagnosis cannot be made before the age of 18 months. That is by using MCHAT or CARS. But earliest the sign can be picked as early as 6 months. So this was the differences between DSM-4 and DSM-5. These were the subcategories in DSM-4: autism, Asperger, PDDS, Rett, and all of them have now been replaced with a single term known as ASD, whereas pervasive developmental disorders are now being absolute. Nobody use those terms. Another important thing in DSM-4, the diagnosis of autism spectrum disorder was very, very complicated. There were 12 behavioral criteria. Out of this, 6 must be met. Then there were another subcategories of A1, A2. So all have been now obsolete. Only there are 2 criteria, criteria B in DSM-5, that is communication and sensory. In criteria A, all should be met, whereas in criteria B, which includes sensory, out of 4, 2 should be met. The another most important thing that the criteria domains which we have discussed, that is social communication and sensory in DSM-5. Another good thing about DSM-5 is the DSM-5 classifies on the basis of the DSM-5. You can categorize the child as per the level of support the child is requiring. That is whether he level of support in the sense of ADL, that is activities of daily living. Does the child require very minimal support? Then we go for ASD level 1. Just give me a second, please. Then, secondly, if the child is requiring substantial support, we label it as ASD level 2. If the child is requiring very substantial support in his daily routine activities like going to brushing, toilet training, buttoning, unbuttoning, lace time, in each every single activity the child requires, then we go at a very substantial support, requiring very substantial support. The greatest advantage of this functional classification of autism is that in DSM-5, it correlates with the severity of the CARS. CARS is a tool, that is Childhood Autistic Rating Scale Standard Division 2. Version 2. This is the standardized global scale accepted tool which has been used for the classification for the severity of autism. The good advantage of this is that as the scores of CARS increases, we can correlate with the DSM-5 criteria for the severity of ASD. So that means to say the car, if the car score is in the severity of 43, 44, that means it is severe. So invariably we can say that the child is coming under ASD level 3. Now this is the peculiarity of this DSM-5 because initially in DSM-4, that correlation between the CARS and the severity of autism as per DSM-4 was not correlating. But now in DSM-5, the severity of CARS correlates with the different functional levels of ASD. I hope I have made myself clear in this. So this is the high functioning ASD. High functioning ASD, we use the word, as I have told you, Asperger's or servant syndrome. So these are some of the lack of social awareness, inability to express emotions and thought. Means to say these are some of the signs which we get in ASD: repetitive stereotypic behaviors, inability to reciprocate, or that is social reciprocity. That means inability to understand the facial expression of others. They are very, very poor towards the facial expressions. They are not able to understand whether it is a whether it what the person is saying and what does the facial expression of the person in front of him justifies. So they are poor in reading facial expressions. And a bit about what is this Asperger syndrome. So Asperger syndrome is basically considered to be a high functioning autism spectrum disorder. It is no different from classic autism. The only difference between them, when we talk about classic autism, which was the term which was used initially in DSM-4, they will have all the peculiarities of autism: repetitive stereotypic behaviors, non-verbal communication, and very agitated, aggressive, not able to interact, not able to read clues, social self-awareness is poor, social awareness is poor. So all those typical features of autism will be present. Whereas when we talk about Asperger syndrome, they are considered to be higher functioning autism, or means to say in a simple word, they are low on cars, or clinically, they are coming under level 1. That means they are coming under mild autism spectrum disorder, which requires minimal substantial support or minimal support in their ADLs. A word about Savant syndrome. So Savant syndrome is a rare condition with persons with significant mental concerns, include autism, have islands of genius. So as I was telling you, there is some subset of some set of people with autism or under neurodivergent, which have great unique abilities, great strengths, and great imagination process. So that classification comes under 7, but exactly they are not 7, but this is the term which has been used. And they say as many as 1 in 10 autistic people have remarkable abilities in varying degrees. Now, this stats is old. Probably if we go with the latest stats, it might be even more than that. Because earlier, if we go about in 90s, the prevalence of autism was 1 in 200. But now, if I go by 2021 stats, the prevalence is 1 in 36. It is the latest prevalence of autism globally. And it is approximately around 200 times more rampant now in 2021 compared to in 90s. So these are some of the 7 skills which we are discussing initially also. Memorization, which is superior compared to the neurotypical children. Calendar calculating and lightning calculations and memorizations. Probably one of the reasons is that because they have very good visual learners compared to auditory learners. Now, autism spectrum disorder, which we were using as per the DSM-5. Now, this is a graphical representation of DSM-5. If you see to this graphical representation, it is so unique compared to DSM-4 because it includes all the surrounding comorbidities like anxiety, depression, OCDs, ADHD, irritabilities. And also, it includes two most important things, that is communication deficits and sensory deficit. Communication in terms coming to the behavior criteria, and sensory, that is restrictive in sensiness to sameness, sensory sensitivities, behavioral, repetitive behaviors, they are coming under the sensory criteria. Whereas social communication deficits, they are coming under the behavioral criteria. So as a result of this, there are only 2 domains which are now being included in DSM-5. Initially, there were 3 domains. So old name for ASD, which has now been replaced with a new term. Now, these are the 2 new terms, that is social communication disorder and SLD, which do not come under ASD. Social communication is a new term which has now been included in DSM-5. It doesn't come under ASD. It is a separate diagnosis from ASD. So this is a slide which shows us how to differentiate between speech language impairment, social communication disorder, and ASD. Now, one of the most important difficult diagnoses when it comes across is how to differentiate between a child on social communication disorder and speech language impairment. Now, many a times, speech language impairment child and social communication disorder child will more or less come under a common platform or in a common domain. The reason is because they are very much differentiated from ASD. ASD children can be easily differentiated because of the restricted interest. They have limited joint attentions, eye contacts, and as we have discussed, they will be have sensory issues. There won't be any symbolic play. It will be more of a more sensory play. The receptive and expressive speech understanding will be poor, stereotypic behaviors will be there. But when I talk about speech language impairment and social communication disorder, because these are some of the differential diagnoses when we talk about neurodiversity or autism spectrum disorders. So SLI and social communication disorder, these are the two most important differentiation diagnoses. So in social communication and SPD, more or less, they won't be having much of problems related to joint attention, interest, eye contact. But the most important problems which they will be facing is they will be having problems in communication. So a child with speech language impairment will have definitely problems in receptive understanding, in receptive speech, that is the ability to understand to certain extent, but expressive speech will be definitely affected. When I talk about social communication disorder, there also the child will be having concerns related to conversation in a scenario. But the difference between the two is a child with social communication disorder will not be able to tolerate the social scenarios, in the sense he will get frustrated in a social scenarios because of the fact that he is not comfortable with the social scenarios or with the social gatherings. It is because of the associated sensory issues which are typically more in a child with social communication disorder compared to a child with a speech language impairment. A child with a speech language impairment will avoid in the social gathering because he will not be able to communicate with them. He will not be able to maintain the communication. Whereas a child with a Whereas a child with social communication disorder will avoid social gatherings because he is not comfortable with the gathering of so many people because of the sensory issues and because of the typical interactions with the social gatherings. The reason which happens because there are no repetitive stereotypic pattern. But the problem is they have sensory issues which are much lower compared to autism spectrum disorders, but are higher compared to a speech language impairment child. Both of them will have pragmatic and syntax issues. Pragmatic issues means there's a formation of sentences will be difficult. Pragmatic issues will be there. But a simple example, if I would give you, and there is a 6-year-old non-verbal child, and he goes into a group of 4 people, and a child who is having a speech language impairment might not be able to communicate, but he might able to do the command on verbal instruction, whereas the child with social communication disorder will not be able to do that command, but instead he will get irritated from those 4 kids and might start pushing and run away from that. So this is how we might be able to differentiate. So it's a very thin line of margin when we come to a diagnosis towards SLI and speech language impairment and social communication disorder. So this is a new diagnosis of SCD which comes under DSM-5. These are the typical, that is, they are the problems with communication disorder. Problems with communication disorder are also there in SLI, but they will be have differences with sarcasm. They are not able to understand the inferences in sarcasm, that is poor facial understanding of expressions of speech, difficulty making friends, difficulty staying on topic, failure to gestures, difficulty taking turns in conversation. That means they are not able to tolerate the social gatherings. And when we do a diagnosis of SCD, it is a diagnosis of exclusion. When you are using card tools or when you are using other tools, that is ADI revised, when a child doesn't come under the autism spectrum disorder, then on the diagnosis you label as a child as SCD because it doesn't fit into the criteria of autism spectrum disorder. If we talk about the tool clinically, as per the DSM-5 we have discussed, because there is no separate tool to make a diagnosis of SCD, we make the diagnosis SCD by the exclusion of ASD. So again, this was when we talk about DSM-4, this was the category of severity to mild, Asperger, PTDS, autism, Rett, and childhood disintegrative disorder. So the severity varied from Asperger to childhood, with childhood disintegrative disorder is the severe or the severe form of autism spectrum disorder. But nowadays we have all removed these terms. We just classify them as mild, moderate, and severe. Again, this is the DSM-5 where only 2 domains were used. In DSM-4, 3 domains were used: social impairment, repetitive behaviors, and speech communication language deficits. We have removed all these 3 domains. We are now just using 2 domains, behavior and sensory. So this is an important slide for us. How that is some of the new terms which has been introduced in DSM-5, which were not there in DSM-4. In DSM-4, all these various terms were there, which has now been incorporated with a single term, autism spectrum disorder. In DSM-4, there was no such term, social communication disorder. In DSM-5, they have used this new term. Rett syndrome was initially introduced in DSM-4. So when we talk about Rett syndrome, we know that it is a typical presentation in female where there is a regression of developmental, where there is a regression of milestones, typically in an age group of 6 to 15 months old child with typical hand wringing movements of flapping hands, which we talk. This was included in the autism spectrum disorder in DSM-4, but in DSM-5 they do not include it. So in DSM-5, Rett syndrome or Rett disorder is considered to be as a separate diagnosis, doesn't come under ASD. Though association with females with Rett syndrome is common, but it is not included under ASD. So reading disorder has now been replaced by dyslexia. So dyslexia was not the term which was used in DSM-4. Dyscalculia was also the term which was not used in DSM-4. Expressive language disorder has now been replaced by language impairment. So stuttering, phonological disorders, which has now been replaced by speech sound disorder. We do not use the word nowadays phonological disorder. It is obsolete. As per DSM-5, we use the word speech sound disorder. And stuttering, which was the old terms, which have now been replaced by childhood onset fluency disorder. So this is for our knowledge that whenever we come across such children, so we feel that these are some of the possibilities. So on a prescription, at least we are familiar with these new terms in DSM-5, which has been now been introduced. So rather than writing a phonological, we might write as a speech sound or SCD or whatever we feel like. So just a bit about Rett affects females, mainly initially develop normally reversal or development or stagnation, loss of language and hand skills, caused by spontaneous mutation in deficit MECP2 gene. As per the ASD, children usually are more verbal. That means it is considered to be a milder form. And these were the old terms which has now been replaced. As I have told you, what was childhood disintegrated. These are some of the definitions and the elaborative meanings of these terms. But I think these are since obsolete, so there is no point in going through them. And they have been replaced by a single umbrella term. So this is just the revised criteria for the Rett syndrome, typical versus atypical, and versus what are the exclusion criteria and what are the supportive criteria for atypical Rett syndrome. So it occurs primarily in girls, 1 in 10,000 to 15,000 girls, loss of purposeful hand movements with repetitive stereotypic hand movements, ringing, clasping, and hand loss of speech, balance, and coordination issues are there. They have breathing problems, and 40% or more or less have ambulatory abilities. So it typically occurs in females with MECP2 gene, where there is a regression of milestones. This is very, very important with typical handling movements, fingers. So just to conclude the today's presentation, I have given I have given two questions so that we just brush up with our today's topic. So I would request that all the delegates to please kindly participate in this. Uh, Sir, I will take up your questions at the end once we finish with these two. So, which of the following statement is not true regarding social communication disorder? So, so the question is, which of the following statements is not true regarding social communication disorder? The first is it commonly mimics ASD but doesn't come under ASD as per DSM-5. So the question is, which is not true? So does it commonly mimics ASD but doesn't come under ASD as per DSM-5? It is predominantly associated with pragmatic issues and less with syntax issues. It is a new diagnosis which has now been included in DSM-4 and doesn't come under ASD. It is a common differential diagnosis for speech language impairment. So which of the following is not true? So the question is, which of the following is not true? So it commonly mimics ASD but doesn't come under ASD as per DSM-5. This is true.
True.
Then, as we have discussed, it is true. So it predominantly associated with pragmatic issues and less with syntax issues. This is also true. We have seen that. And it is a new diagnosis which has now been included in DSM-4 and doesn't come under ASD. Now this is wrong because it is a new diagnosis which was not there in DSM-4. It has now been included in DSM-5. So DSM-5 should be there. It is a common differential diagnosis speech language impairment. This is true. So the third answer, the third option is not true. So we will go with this third option. Yeah. So let's come to the next question. So a 4-year-old male child, I'll just read it. A 4-year-old male child comes to the pediatric clinic with mother. She complains that his son speaks a lot. He has more than 1,000 vocabularies and talks a lot at home, but he is sometimes not able to answer other people's questions relevantly. He gets irritated while playing board games or games involving rules. It becomes very difficult for him to teach games. The child behaves differently in social scenarios, like on one occasion, he didn't talk in a birthday party or sometimes keeps self talking on a family dinner. The mother says he is able to understand routine things like go to kitchen, but sometimes might get confused in more complex commands. His understanding appears to be good. He has recently started showing frustration, anger, and avoid interacting with relatives and friends. Though he has good reading skills, his academic performance is also getting affected as he is showing behaviors in school. He loves to mingle, interact, and enjoys playing with younger children but avoids with peer group. What is the most likely diagnosis with this child? Autism spectrum disorder, social communication disorder, speech language impairment, or learning disability? So there are some catch in this question, and probably I think we have discussed on this. Yes. See, at first point of time, there are two things where we feel there are two things that social communication and speech language impairment. These are some of the two most close options which we appear. And learning disability is unlikely to be in this child because, as it has mentioned, he has good reading skills, but academic performance is being affected because of those behaviors. So, coming to this, social communication disorder appears to be a more relevant option because, as they mentioned, that the mother feels that he has a good vocabulary of 1,000 words and he also interacts with family members comfortably. But in social scenarios where there is a group together of family, friends, and relatives, he's not very comfortable. He doesn't like to interact. He starts showing behaviors. And as we have discussed, because of the probable sensory issues which might be there, though it has not been mentioned anywhere in this, but the scenario which shows in this question appears to be more relevant with the social communication disorder. So I think most of us will agree with this that the child might be having a social communication disorder rather than with a speech language impairment. And autism and learning disability doesn't appear to be in this child. Yes, so some of them have answered, and yes, it is a social communication disorder in this child. So yeah, so thank you everyone. So this was a bit about the redefining and understanding autism spectrum disorders as per DSM-5, and also updating our thoughts regarding the topic on neurodiversity and how this neurodiversity and autism are related. And yes, I think there was a question by Dr. Vipin. Yes, sir.
Yeah, Dr. Lalit, it was a nice interaction. My main question is that am I audible?
Yes, sir, you are audible.
My main question is when we send, say, an 18-month-old child for assessment,
Yes.
and if the child is very uncooperative,
Hmm.
how you are able to assess? Are you able to assess in one sitting, or you need more than one sitting? And
Yes.
finally, when we get the report, that report sometimes itself is so confusing for the parents as well as the referring doctor that he is not able to understand that whether the assessment has been done rightly or wrongly. The person who has assessed the child, we can believe him or not, because sometimes if we get the same child assessed from two people, we get different reports and the actions suggested are also different. So sometimes it will becomes very confusing that should we take some more time to so that we can come out with a final answer, or at 18 months itself we should try our best to make a diagnosis or a final diagnosis instead of a provisional diagnosis, because provisional diagnosis comes a lot. Probably this is there, probably this is there, this can also be there, but when can we make a final diagnosis of a child who is normally uncooperative at 18 months of age?
Yes, sir. So your query is absolutely right, and it is very genuine. This is a major problem which we feel. Now the thing is, there are certain prerequisites which we need to encounter when we are dealing or making a diagnosis of a child with autism spectrum disorder. The first and foremost thing is we generally ask with some of the early features. Now we directly don't go on to a tool. We initially go on to the history taking of the child, especially when we come across the developmental milestone. What was his time of creeping? When did he start crawling, creeping? When did he start walking? We observe the child. Initially, we observe the child maybe for 20, 25 minutes. How about his interaction with the environment? How does he play with it? Does he show any pointing? Does he understand the term mama and papa? Does he go to the mama and papa on telling questions? And also we should go for taking the history that if there are 4 to 5 members, if we tell go to mama or where is papa, touch papa, an 18-month-old child should do those things. Then we try to understand how about his gross and motor skills. Does he able to hold the pencil? Does he able to scribble? So all those sittings, is he able to mingle with some toys? We just throw toys to the child and see how does he observe. Does he have an explorative nature? Does he try to explore different sorts of toys? Or does he going and doing sensory touch continuously with a particular toy? And does he doing stereotypic movements like rotating wheels of the car? Does he observing with side corners, that is sensory? Or does he keep looking from the side corners? Does he observing some rotating objects or having some fixations? So these are some of the observations which we do before directly going on to the tool. So this is first thing, observation. Then comes the developmental history. You should take a detailed developmental history of the child starting right from the birth. What about his neck holdings, creeping, crawling? The importance of these is creeping and crawling, but sometimes in many of the cases, their STNR, that is symmetrical tonic neck reflex, is activated. And many a times we see that the mother will give a history that they did creeping, but they forget crawling and directly they start walking. So this is, or some of the times we will get a history that he started creeping and crawling by the age of 7 to 8 months or 9 months, and he's by the come he's still he continued creeping till 15 months, and now he started walking. So there is a delayed history of walking. So all those things need to be noted. That is observation, detailed clinical history, and then if you are sure, if you are 100% sure with the observations and clinical history, then you directly apply CARS. Now, CARS which is applied, it is in consideration with the observation and the history, because on CARS you are directly asking questions to the mother, parents. It is more of a questionnaire. So there you are not doing much of the assessment. Assessment is an added thing which you need to do and correlate when you are doing the scoring of cards. If you directly bring the child and just ask the question without seeing the child, without observation the child, many a times your scoring will be wrong. Reason because when we tell the mother क्या ये बच्चा पॉइंट करता है, उनके लिए पॉइंटिंग होता है अगर वो हाथ भी ऐसे दिखा दे, हाँ ये ऐसे कर रहा है. बट फॉर अस पॉइंटिंग मीन्स दिस थिंग, इट शुड बी लाइक, बिकॉज 15 या 18 महीने का बच्चा अगर हम बोले आपको क्या चाहिए, वो अगर नहीं भी बोल पा रहा, he will clearly point with the index finger. But for the parents, sometimes those who are educated or they are aware with these things, probably they might. But many a times वो सिर्फ हाथ भी ऐसे कर देगा, which is known as hand lending, उसको भी वो pointing बोलेंगे. So that is why your observation, your clinical observation with tool scoring is very very important. अगर हम 100% sure हैं, then only we directly go for the cars. Otherwise, initially you should go for an MCHAT which is revised. उसके अंदर you categorize the child as mild, moderate and severe, depending upon that is high risk, mild risk or severe risk. And then if the child is coming under mild to moderate, if it is coming under mild, you tell probably the reason could be in that scenario, it could be high screen time. So observe the history of screen time. Is there an only child? ये सारे दिन घर में है, कोई बात करने को नहीं है. All those things need to be taken. And then you tell them reassess after 3 months. अगर reassess after 3 months में भी वही स्कोर आता है, माइल्ड या मॉडरेट हो जाता है, then we should go for the cars. So cars इनिशियल लेवल पे हम जब ही करते हैं अगर बच्चे का एम चैट मॉडरेट या सिवियर आ रहा है, या आपको 100% क्लियर साइंस मिल रहे हैं, yes these are some of the early signs, and yes you go apply for the cars. Why I'm telling you, because all these features sometimes might also come out in a child with GDD, global developmental delay. बिकॉज जब हम ग्लोबल डेवलपमेंट डिले की बात करते हैं उसमें टू मोस्ट इंपॉर्टेंट डोमेन्स, मोटर एंड कॉग्निटिव इज अफेक्टेड. एंड मोटर जो पार्ट है, ग्रॉस मोटर एंड फाइन मोटर, वो डेफिनेटली चिल्ड्रन स्पेक्ट्रम में होगा तो इफेक्ट होगा ही होगा. सो अगर कोई बच्चा ऑटिज्म का डायग्नोज है किसी बच्चे का, डेफिनेटली जीडीडी विल बी देयर इनवेरिएबली, बट अ चाइल्ड विद जीडीडी मे नॉट हैव ऑटिज्म. So this is very, very important when you are labeling a child with autism. You can keep your working diagnosis as GDD up till the age of 5 years. But that GDD comes out either in a form of an autism or maybe ADHD after 5 years. That is a different thing. But under 5 years, if you are in doubt and if you feel some of the issues are there, but it is not coming clearly under this, you can keep it as a GDD or working diagnosis.
Hmm. Sir, here I just wanted to ask one question again.
हाँ जी।
History is important. Okay, parents will give the history. As far as
हाँ
observation is concerned, sometimes we
हाँ
are not able to observe the child because the child keeps on crying. He will always ask the parents, घर चलो घर चलो,
सर।
यहाँ पे नहीं रुकना
सर
है। वो कोई
उसमें
कमांड
हाँ।
फॉलो ही नहीं करेगा. He will
सर
not follow
एग्जैक्टली।
any of your command. He will just keep on crying
एग्जैक्टली
by seeing.
एग्जैक्टली सर। हाँ बिल्कुल सर, वही चीज सी, वही चीज हमको देखनी है, बिकॉज द चाइल्ड, एज आई हैव टोल्ड यू, DSM-5 में सेंसरी कंसर्न्स भी आ चुके हैं, सेंसरी इश्यूज हैज आल्सो बीन इंक्लूडेड। प्रॉब्ली दैट क्राइंग इटसेल्फ is coming as a sensory meltdown for that child. It might be a new environment for him. It might be a separation from the mother कि मुझे ये डॉक्टर लेके जा रहा है कुछ करवाने के लिए. It might be a new cumbersome environment कि मैं यहाँ कहाँ गया. It might be a separation for him. He might not be comfortable with my bright lights in my room or in my cabin. He might not be comfortable with the texture where he is touching the things or where he is going. So all those things might come in a child. That is why we have incorporate this sensory criteria in DSM-5. अब 18 महीने का बच्चा जो बोल नहीं सकता, कुछ नहीं कर सकता, ही माइट बी जस्ट क्राइंग एंड वी माइट शो दैट ही इज नॉट कंफर्टेबल, उसको थोड़ा सुला दो या कर लो. मेनी अ टाइम्स बच्चा अच्छे से सो के आ रहा है, फीड करके आ रहा है, उसके बाद भी वेन एवर ही एंटर्स इनटू द एनवायरनमेंट ही जस्ट स्टार्ट्स क्राइंग विदाउट एनी रीजन एंड देयर इज नो रीजन टू स्टॉप हिम. प्रॉब्ली ही माइट बी इन दैट स्टेट, इन अ स्टेट ऑफ सेंसरी मेल्टडाउन, जो हमको नहीं दिख रहा और जो सामने हमारे सामने सिर्फ क्राइंग के एपिसोड्स में आ रहा है. अदर रीजन जो आपने बताया वो ये हो सकता है कि बच्चा पूरी अच्छे से सोया नहीं है, बहुत लंबी ट्रैवलिंग है, 2 घंटे करके आ रहा है, या कुछ मेडिकल इश्यूज है, कंसर्न्स है, कॉलिक्स हैं. वो चीजें हमको जरूरी प्री रिक्वेजिट्स में देखनी है बिफोर व्हेन वी आर वर्किंग विद अ चाइल्ड. क्योंकि हम ये हमेशा बोलते हैं जब भी आप आते हैं असेसमेंट के लिए, बच्चा अच्छा सा खाना खा के आए, उसकी नींद अच्छी सी हो एंड शुड नॉट बी सफरिंग फ्रॉम एनी फीवर और एनीथिंग, या यू आर है या सिंपल कोल्ड एंड ऑल. वो भी एक फैक्टर है जहाँ पे बच्चा क्रैंकी हो सकता है और हमको कुछ समझ ना आएगा और एसेस ना कर पाए.
हम्म. Right, sir. Thank you so much. Thank you.
Thank you, sir. Thank you. Any other questions from the delegates?
Sir, can I ask a question?
Yeah, ma'am, please.
सर लाइक अभी जितना भी हमारा डिस्कशन हुआ कमिंग
हाँ जी.
वे टू दैट, मैम सर जब हम लोग प्रैक्टिस करते हैं आइडियली ये जो भी टेस्ट, अगर आप लेबलिंग के पॉइंट ऑफ व्यू से देखें तो प्रोविजनल डायग्नोसिस जैसे सर ने कहा कई बार मिल जाते हैं हम लोगों को, या फिर मोस्ट ऑफ द टाइम्स कई बार मैंने ये भी देखा है मेरे प्रैक्टिस में कि एडीएचडी विथ एएसडी ऐसे भी हमको
हाँ.
लेबल्स मिल जाते हैं. बट
हम्म.
सर जो फंक्शनल असेसमेंट्स है वो तो इंडिया में होते नहीं है. तो आप कुछ टिप्स दीजिए हमें कि मतलब हम किस तरीके से अपना प्रोसेस स्टार्ट करें, और हमें कुछ चीजें मतलब जो आपको लगा होगा आइडियली आपकी प्रैक्टिस में कि जो आप हमसे शेयर कर सकते हैं कि हम किन पॉइंट्स का मतलब मेजर ध्यान रखना चाहिए. बट एज एन ओटी हम बहुत सारी चीजों पे मल्टीपल फैक्टर्स पे, सेंसरी एरियाज और जो भी प्रिमिटिव रिफ्लेक्सेस हैं, स्किल्स हैं, ग्रॉस मोटर, फाइन मोटर, इस एरियाज में हम लोग एक्चुअली असेस करते हैं. बट जैसे कि आपको पता है कि मल्टी डिसिप्लिनरी अप्रोच होता है, और जो मुझे
हम्म.
अभी तक प्रैक्टिस में जो डिफिकल्टी रियलाइज हुई कि जैसे आपको पता है कि सेलेक्टिवली हमें हर चीज को मतलब जनरलाइज करना पड़ता है, वेदर इट बी एजुकेशनल स्किल्स हो, चाहे हम ओटी स्किल्स हो, चाहे वो बिहेवियर हो. तो जो बिहेवियर का जो फैक्टर है, जो साइकोलॉजिकल कंटेंट है, जो हमने पढ़ा है कि जो थ्योरी ऑफ माइंड या फिर जो एग्जीक्यूटिव फंक्शनल्स में जो डिफिकल्टी आती है, ये सेम डिफिकल्टी हमको जब हम लोग ओटी में ट्रीट कर रहे होते हैं तो वो बिहेवियर्स के फॉर्म में एग्जिबिट होती है. तो उसके पॉइंट ऑफ व्यू से आप मुझे मतलब कुछ सजेशंस दे सकते हैं आप हमको कि हमें किस तरीके से मतलब प्रैक्टिस के पॉइंट ऑफ व्यू से बोल रही हूँ कि हम कैसे असेस कर सकते हैं इन पैरामीटर्स को.
देखिए, आपका नाम?
सर डॉक्टर गायत्री सिन्हा.
ठीक है, ओके. डॉक्टर गायत्री, देखिए, आपने जो सबसे पहले चीज बोली फंक्शनल असेसमेंट, इंडिया में फंक्शनल असेसमेंट है और बहुत अच्छे से हो सकती है. उसका हम यूज करते हैं, जो हम नॉर्मली यूज करते हैं, जिसको वो वैब्स, विनलैंड एडेप्टिव बिहेवियरल स्केल. अब विनलैंड एडेप्टिव बिहेवियरल स्केल एक इतना अच्छा टूल है जहां पे आप बच्चे की फंक्शनल एबिलिटीज जज कर सकते हैं. जैसे जब हम एडीएल्स के बारे में बात करते हैं, क्या वो बटनिंग करते हैं या बटनिंग कर पाते हैं, तो देयर आर सो मेनी थिंग्स विच आर देयर विच आर वेरी विच विल एक्चुअली गिव यू एन अडेप्टिव फंक्शनिंग ऑफ दैट चाइल्ड. तो नॉर्मली जब मैं अपनी अगर बताता हूँ, तो नॉर्मली अगर मैं बच्चे का डायग्नोज बनाता हूँ या कुछ कर रहा हूँ या कुछ स्कोरिंग आती है, तो आई ऑलवेज गो विथ कोरिलेट विद द वैब्स. क्योंकि वेब से हमको एक ये आइडिया मिल जाएगा कि जो आपकी स्कोरिंग है और जो आप अपने बच्चे को सोच रहे हो कि ये सिविरिटी है, वो उतनी ही वेब्स में उसके प्रॉब्लम्स आएंगे। सो अगर हम वेब्स की डिफरेंशिएशन करते हैं तो डिफरेंट यही आता है कि पुअर है, वेरी पुअर है या माइल्ड है। तो उसमें आपको बच्चे की अडेप्टिव फंक्शनिंग मिल जाएगी कि क्या वो अपनी खाना खा सकता है, या स्पेलिंग होती है, या चल सकता है, या बटनिंग अनबटनिंग होती है, टॉयलेट ट्रेंड है, शर्ट पहन सकता है, कपड़े पहन सकता है, लिख सकता है। सो देयर आर सो मेनी थिंग्स इन दैट। सो ये एक पार्ट हो गया आपका अडेप्टिव का, जहां पे हम बात करते हैं कि हम उन चीजों को जज कर सकते हैं। दूसरी चीज आपने बोली जैसे बिहेवियर्स। अब बिहेवियर्स आपने बोला कि ओटी में करते हुए या काम करते हुए आपको बिहेवियर्स मिलते हैं। अब वो हमको जज करने हैं, उन पे हम कैसे काम कर सकते हैं। तो ब्रॉडली अगर मैं बताता हूँ, बिहेवियर्स हमारे ब्रॉडली चार टाइप्स के होते हैं। दे आर ओनली यूनिवर्सली देयर आर ओनली फोर कॉजेज ऑफ बिहेवियर विच नीड टू बी टैकल्ड, वेदर इट इज अ न्यूरोटिपिकल और इट इज अ न्यूरोडाइवर्स चाइल्ड। अब अगर मैं न्यूरोडाइवर्स चाइल्ड की बात करता हूँ, हमारे पास फोर बिहेवियर्स के कारण है। फर्स्ट एंड फॉरमोस्ट इज अटेंशन सीकिंग बिहेवियर। सेकेंड इज मेडिकल कॉज। थर्ड कॉज इज escape or avoidance behavior. Fourth causes tangible behavior. And the fifth causes sensory issues. So अगर हमारे पास ये पांच कॉजेस बिहेवियर, बच्चा कोई भी बच्चा बिहेवियर शो कर रहा है, इनमें से कोई ना कोई पांच कॉजेस होंगे। और जब भी हम भी अब इनका अगर मैं एग्जांपल दूं, एक बच्चा है, मदर ने बोला ब्लैक बोर्ड आपको पेंसिल से नहीं लिखना। एक न्यूरोटिपिकल का एग्जांपल देता हूँ। वो पेंसिल से लिख रहा है, स्क्रिबल कर रहा है वॉल पे बार बार। मदर मना करती है नहीं लिखना, वो दोबारा लिखता जाता है। अब जैसे ही मदर चली जाती है वो लिखना बंद कर देता है, मदर उसकी तरफ आई कांटेक्ट देती है, वो दोबारा लिखना शुरू कर देता है। दिस इज अ टिपिकल एग्जांपल ऑफ एन अटेंशन सीकिंग बिहेवियर। एक बच्चा है, वो स्कूल में जा रहा है कंफर्टेबली एंड सेंसरी ही एकदम इमीडिएटली जैसे ही वो स्कूल गेट में एंटर करता है, ही स्टार्ट स्क्रीमिंग शाउटिंग। पेरेंट्स को नहीं समझ आता व्हाई ही इज डूइंग दैट, ही इज अ चाइल्ड ऑन द स्पेक्ट्रम, बट एकदम से एंटर करते ही शोर मचाना शुरू कर देता है, क्राई। सो व्हाट इज अ कॉज फॉर दैट? इट माइट बी एन ऑडिटरी इश्यूज, इट माइट बी अ overwhelming response which is getting, because we know that children on spectrum, they have a very overwhelming response to the sensory stimulus. So that might be a cause which is giving him a so much crying, or wo crying episode might be because there is a sensory meltdown which is going in the child. Another reason might be बच्चा communicate नहीं कर पा रहा है इस क्लास में, और उसको सुसु जाना है या पॉटी जाना है, is not able to express, he's just screaming, shouting or banging the table. So what does he want? He wants to take an attention from the teacher, that please kindly look and give me an attention. This. So there might be so many things. Other child might be showing tantrum because he wants that toy. That is a tangible behavior. Once you give it that, he settles down. Whereas a child who is having a sensory meltdown, even when his demands have been put, he will continue to cry because he has gone in a state of sensory meltdown. सो ये हमारे कॉजेज हैं। और जब भी हम बिहेवियर मैनेजमेंट की बात करते हैं, हमको एबीसी अप्रोच करनी होती है, एंटीसीडेंट, टारगेटिंग द बिहेवियर एंड कॉन्सिक्वेंस। नॉर्मली हमारी अप्रोच होती है कि बच्चा ये बिहेवियर शो कर रहा है, उसको रोक दो। दिस इज एब्सोल्युटली रॉन्ग। हम बिहेवियर को डायरेक्टली कभी नहीं टारगेट कर सकते, वी हैव टू टारगेट द एंटीसीडेंट रीजन, द एंटीसीडेंट थिंग, व्हाट इज ट्रिगरिंग द बिहेवियर। एंड वंस वी डू दैट, then you target and then you provide the C, that is the consequence if it does something wrong, or whatever, whether you want to give a positive reinforcement or a negative reinforcement. So that we'll discuss in the behavioral management part, but since आपने ये behavior की बात करी, so I'm giving you this example for that. I hope I am able to answer your question for that behavior.
was very valuable input. बस एक चीज और मुझे बता दीजिए सर कि ये जो असेसमेंट आपने बताया वेब, हु इज क्वालिफाइड टू डू दैट?
वेब्स अगर आपको लगाना आता है आप लगाइए। डेवलपमेंटल पीडियाट्रिशियन इज जनरली क्वालिफाइड, क्लिनिकल साइकोलॉजिस्ट इज क्वालिफाइड टू डू दैट। बट द थिंग, आपको अगर वो लगाना आता है तो यू कैन अप्लाई दैट, because many a
ओके
times
ओके
अगर वो टूल नहीं यूज कर रहे, even if I am a developmental pediatrician, if I am a clinical psychologist, but if I am not using that tool regularly, then definitely I will not be able to use that. So अगर आप continuously use करते हैं and you are in touch, you will be able to use that. So WABS 4 is the latest which is being used for checking the adaptive functioning of the child. Okay.
So do you have a time? Like I have one more question if you don't have any questions lined up ahead. Can I ask you a question?
Please, I will take up your last question here, please.
Okay, okay.
Any other questions? So I think we are already crossed 4. So Dr. Gayatri, I will take up your question. Yeah, please tell. Then this will be your last, and then we'll close up with the session.
Sir, how would you define hyperactivity? Because most of the time it has become a very loose term right now. Because sometimes even if the kids are showing behavior, still the parents and other caregivers or maybe some clinicians also define कि बच्चा अभी बहुत ज़्यादा hyper हो रहा है. So and it differs from point of view of ASD as well as ADHD. So please give me proper definition of what you mean by hyperactivity.
देखो, if I talk about proper definition of hyperactivity, ठीक है, when we use the term, now this hyperactivity term I am giving you when we are using it in terms of labeling a child on ADHD, ठीक है. So whenever we label a child on ADHD, hyperactivity means the child is hyper active in response to the peers in different scenarios. मतलब he should be hyperactive in more than 2 settings. जनरली ये होता है बच्चा स्कूल में टिक नहीं रहा, इधर उधर भाग रहा है, इधर भाग रहा है, उधर भाग रहा है, लेकिन घर में आराम से है. So will you label this child as an hyperactive under ADHD? You will not label it. Because when you are labeling a child hyperactive under ADHD, he should be hyperactive in 2 or more than 2 settings. The hyperactivity should not vary from the scenario. It should not vary from scenario to scenario कि मम्मा के पास है तो बहुत शांत है, पापा के पास है तो hyper है. He is not an hyperactive child. A hyperactive child will be hyper in all the scenarios. This is one of the most common findings which we misjudge whenever we are labeling a child as an hyperactive. एक तो ये. Another thing, hyperactivity cannot be used unless and until the child is 4 or more than 4 years. Below that, you can use an overactive term. Overactive is something which is a nominal term, but hyperactive is a term when you are using in medical terms. Overactive can be a layman term कि overactive है, चंचल है, tantrum throw करता है. But when you are labeling as an hyperactive, then it becomes a pathological or developmental or neurodiverse, whatever terms you use. Then in that case, you have to be very peculiar that on what grounds you are labeling it. So normally when we are using the term hyperactivity, one tool is corner rating, and hyperactivity जब हम use करते हैं, he should be hyperactive in the sense he should not be able to wait for his turns. He should be running here and there. The waiting time is very, very low. He cannot wait for his turns. He cannot wait for his turns in the class. The teacher tells, he writes very quickly and immediately finishes within 5 minutes with all Z things. So these are some of the typical examples which we get when we are dealing with a child on hyperactivity. But all these things should be present in 2 or more than 2 settings. Environment. Not only in school, but it should be other than school. It should be similar in the house also. Okay. Dr. Gayatri, I think anyhow. Okay. So I think we can thank you very much. Thank you very much, delegates, for the attending for today's webinar. So next Saturday, we'll be coming up with the next topic on our e-summit, and we'll be sharing you shortly the topic of presentation on that. And thank you, everyone, and hope we had a nice discussion on this. Thank you, everyone. Thank you.